program chair, I offer to take the chair Professor Khandakar Kamrul Islam, Professor APM Shoravuzzaman, Professor Abdul Wadud Chaudhuri, Professor Abdul Qadir Akando, and Dr. Khandakar Shohid Hussain, Professor Saidur Rahman Khan, and Dr. Kaisan Nasrullah Khan. And as you know, our live case operator today, Dr. Gabriele Gasparini and Dr. Bernhard Reimers, both of are the course director of total occultation bifurcation intervention. And I am very glad to introduce more Dr. Damiano Rajagoli. He is also Cath moderator and IVUS commentator. And live case discussion, Mustafa Jaman, Professor Abdul Rauf, Ashish De, Dhiman Bonik, Mahbur Mansoor, and Dr. Mutaleb Hussain and Dr. Rasul Amin. Before going to our session, have a quick look for promo from Italy, right? Okay, now I am introducing our president, Professor Akam Fazlur Rahman. He is the president of Bangladesh Society of Cardiovascular Intervention, as well as our all EC member are still online, and our distinguished faculty also over there. And we think we should proceed. We have to enjoy your case, and step-by-step discussion will be going on. Now I am requesting Dr. Ashok Dutta, please introduce yourself as well as you can proceed the further events.
Yes, thank you, Professor Azam. So good afternoon, good evening, good night to everybody, and welcome to the live case from Milan, from Humanitas Research Hospital. This is a very specialized hospital, highly specialized hospital, and both of the operators are very well known and CTO specialist as well. I'd like to thanks and express my gratitude to BSCI for arranging such session. I think after lunch, many of us are a bit sleepy, but live case from Milan, I think that will help them to keep alive. So I like to request Cath moderator, Dr. Damiano Rajagoli, to introduce yourself, your Cath lab faculties, and also the case in summary, please.
So thank you very much and welcome here in Milan. For us, it's early morning and not so early. We are in fact at 10 o'clock in the morning, so we are quite awake to present this case. Here with us, obviously, Gabriele Gasparini and Bernhard Reimers, that is the chief of our interventional cardiology. They are going to show you a nice case of long LAD, calcific LAD reconstruction. Plus, we have here with us Roberta and Alessandra, two super gifted nurses that we will work with us. So we will show you this case, Sandro, of long and calcific LAD. In fact, it's really a debatable case. We know that he's a very young gentleman, 55-year-old, with normal BMI and with an history of effort angina in the last few months. He suffers from hypertension, dyslipidemia, and now he quit smoking in the last couple of weeks. And in fact, he underwent echo that is normal, stress test that is pathological, and a coronary CT scan that showed 3-vessel disease. We will show you the angio. This is the angio. In fact, it's quite a mess. It's a long diffuse disease of the proximal RCA with a subocclusion of the distal RCA towards the PDA and posterolateral branch. The vessel is quite large with a good distribution. And on the left system, the situation is even worse. In fact, we can see here a diffuse disease of the whole left coronary system with some calcification on proximal left main and the ostial left main 2, and the really long and calcific disease of LAD that you can see here in the middle chart. And in fact, we know also that the lesion in the mid part of the LAD seems really calcific with probably the need of some type of plaque debulking if percutaneous strategy is selected. In fact, the patient was studied more or less 20 days before today, and we found out that due to the diffuse and calcific disease, the syntax score was more or less 42, and this patient, if evaluated with a clinical and angiographical score like syntax 2020, would have been probably directed towards CABG, because we expected some type of survival benefit over the next 10 years. The patient is really young, 55-year-old. In fact, the patient after discharge, because we discussed with him and with the cardiac surgeon, and we proposed obviously surgery as a first option, the patient called back after discharge, a couple of days after discharge, and categorically refused surgery due to personal and also to work reasons. So in fact, we had to accept this decision, and we call him back to show you this case of really long LAD. So Gabriele, Bernhard.
So hello. We are
Hello,
really
Gabriele.
proud and happy that we can join you in Bangladesh, Heart Association. It's a great honor for us. And of course, we know Ghulam Zaman and Dutta. You are good friends of Toby and good friends of us, of course. And so we are very happy to connect to you today and share this case with you. And thank you for having us. I don't know whether you want to say something else,
No,
Gabriele?
I would like just to say thank you once again to the Bangladesh Society of Cardiovascular Intervention for kind invitation. We are delighted to join your annual meeting. So it's a privilege for us to have the opportunity to to share our knowledge with you and to discuss together regarding this very complex and interesting case. Before starting the case, we would like to know also from the panel and from the moderator their opinion about this case and overall about the strategy to offer to this patient, because of course it's a very young patient. So the first therapeutic option, has Damiano underlined, is the surgery, but the patient refused the surgery. So we have to be able to offer to this patient the best solution, that the best percutaneous solution that we can do it. So it's open to discuss with you about the best strategy in order to achieve also a good outcome.
Thank you.
I think Dr.
So-
Ashok Dutta, can you come forward to say something?
Yes. Definitively, I like to just request our chairpersons. I think Professor Saidur Rahman Khan and Professor Abdul Qadir Akan sir is here. Any opinion regarding the strategy of revascularization by PCI?
I think you should mention single one, right? That's why don't
Yes.
get any confusion, right?
Dr. Saidur Rahman. Yes, Akan sir. Yes.
Okay, Saidur Rahman, let him tell and then I will discuss.
Yeah, Dr. Ashok, can you hear me now?
Yes, we can hear you.
Okay, so in Milan, I think it's in the very early morning, you are facing with a beast-like calcification in all the 3 territories, isn't it? And what should be the strategy? So my question is here, whether you are going to go for a total revascularization at the same day, or you will have a stage procedure, like dealing with the left main and the LAD first, and then later on you'll go for RCA the next day, or at the same day?
No, today we will address the LAD, which is
That's better. That's
quite
better,
longish, and although you can see in this projection We already have some collateral flow
Collaterals in there.
to the right, which is suboccluded distally. And we decided today we'll address this lesion, and I think it's complex enough for today.
That's true.
Okay, if he finishes in
So-
5 minutes, we go for the right, but I doubt that.
Yeah.
Okay, in
yes,
that case, what are the armamentarium you are going to?
You
be
have
in
to
your
tell
hand
us.
to plan?
You have to tell us.
Like a road, just starting from the cutting or scoring, and then going to the rota, and then later on the IVL. So I think all the armamentariums are there, right?
Yeah, sure. But
Let's see then what would happen, because your mid RC has got a huge torque. So I think it's better to go for the stage procedure the next day.
Yeah, sure. Before starting the case, I would like to also to specify our setting. We are using right radial, advancing a glide sheet slender that is ultra thin walled sheet that led us to advance without any problem a 7th French guiding catheter through the conventional radial access. We are also used to advance this kind of the device also through the distal radial access. And we are advancing a 7th French side-hole 3.5 EBU guide catheter, because as you can appreciate from this angio, there is also a critical stenosis of the ostium of the left main, and also a severe calcification of the body of the left main, and also the level of the bifurcation. And so for this reason, we decided to today just to treat the LAD and the left main.
Yes, and the first guiding catheter was without side holes, and then it dumped, it occluded very importantly. And if you can see the pressure trace, despite having the side holes, you still can see it ventricularize the curve. So it's definitely a lesion we have to address, and probably the left main until the ostium needs treatment here.
Yes.
And
So
again,
Akando, any opinion, sir?
take another opinion from Professor Akando.
Actually, this is basically this is a good case for surgical procedure, and surgical outcome is expected to be good. But even the surgical treatment is not enough to produce the complete revascularization in this patient, because there is stenosis at the bifurcation point of the right coronary artery. So I think the hybrid procedure will be better for this patient. But as the patient refuses surgery, so I think the approach to the left main and LAD in the first setting is my opinion. That should be the opinion in this patient.
Thank you, sir. Thank you.
But as the patient has got the narrow caliber left main artery is not very wide caliber. That is also narrow caliber and calcified from its origin. So we have to stabilize a LAD as well as the left main and also the ostium of the left main. And in this situation, might need the rotablator support that Professor Saidur Rahman already mentioned in this patient.
Yes.
That's great, sir. Thank you very much. Actually, the question is that the patient needs revascularization strategy, whatever you like, but they clearly showed syntax score is very high. He need revascularization, but he categorically declined to go for surgery. That's why we go for the strategy. But question is that we should go for just fix the LAD or with total revascularization. But now their strategy is go for only fix up the LAD, then go for the further
Revascularization to the RCA in later day.
Near future, right?
Golam. Now we are performing IVUS because in this kind of lesion, an IVUS, an image, core intravascular imaging, it's mandatory in order to decide and to tailor the best strategy for the plaque debulking because of the large amount of calcium. So you can appreciate the IVUS now, and then we can also see once again the IVUS run in order to discuss together the IVUS finding and also the best strategy that we should decide to perform.
We also, Antonio Colombo joined us here.
Yes.
He worked with us. And
nice to hear, Dr. Colombo. Nice to see you.
Hello, hello.
Our
Hello.
mentor.
Yeah,
Very nice to
acknowledge.
comment this
Thank
case.
you.
So I think the first information that we get from IVUS is that the fact that the IVUS catheter was able to cross, most of the time you don't need a rotational atherectomy. So you don't really need to activate the IVUS, just advance the IVUS catheter. And if the IVUS catheter is able to go distally, you can definitely try with high pressure balloon. This does not mean that you will not use rotablation, but you are definitely authorized to try high pressure balloon. Regarding surgery, you know, I think surgery is always a good option, but modern angioplasty has never been evaluated against surgery. We still are attached to syntax trial, which is a very outdated study with an old stent, a strategy that is not used anymore. Total occlusions were only successful in 40%. Nowadays, they are successful in 80%. FFR was not used in syntax and IVUS rarely. So I think this idea that surgery is better for complex lesion still needs to be proven with contemporary angioplasty.
Okay.
Yeah, Dr.
And-
Colombo, just I want to say that again you are just telling some beautiful observations of yours, which are very, very much important all the time. Like this one, that the IVUS catheter, if it is crossed through this long calcification, starting from the distal left main up to the mid LAD, and it means that it doesn't need a rotational atherectomy possibly.
I
That's a
wouldn't say
great
it doesn't
observation.
need
That's a
it's
great
not
observation.
mandatory. It's
Yeah,
not
that's I'm
mandatory.
telling. That's a great observation because it's not written in the books like this, but it's really true because so sometimes in my personal experience also I see these things that if IVUS catheter goes means it works well, that the calcification is not that much hard enough to go with the rotational atherectomy.
Yeah.
Okay, that's great. But Colombo, do you think any role of IBL?
Any role of
IVL.
IBL
Intravascular
intravascular in that particular case?
we differ, Dr. Colombo, we differ from IBL as because IBL is for localized calcification, 360-degree localized calcification for a balloon length. You cannot do the IBL entire vessel.
Yes.
It is
But you know, before trying IVL intravascular lithotripsy, which is a very expensive device, I would try high pressure balloon.
Yes.
What's wrong?
That's
If high
right.
pressure balloon expands well, you keep the money for something else. Depends. If you are selling IVL, it's a different story. But if you buy IVL, it's a different story.
Dr. Colombo, we want to see the IVUS findings of left main as it seems to be narrow, but it does not become same as because narrow as because LM is 2/3 of the sum of LAD and LCX. LAD is bigger, but LM is narrower. So I think there is dia in the LM. So by IVUS, we would like to also see the dia of the LM.
Yeah, but I think maybe you can evaluate the left main after having treated the
That's
LAD. Maybe do an FFR of the LAD at the end and make an evaluation of the left main. No, this
Whether
patient,
2/3 of the high pressure balloon, 2/3 of the diameter high pressure balloon you are taking, or 1:1?
I think 1:1, 1:1.
Okay.
It is
But
usually
you know, it's a little bit maybe slightly undersized, not 1:1 exactly, because every time you go with a high pressure balloon, even if non-compliant,
Yes.
becomes a little bit bigger. So slightly under a 1:1.
So we would like to review the IVUS finding. Damiano, what do you think?
There is
Just-
a distinct plaque at the distal left main in the cranial view.
Okay, so besides, and thank you, Prof. Besides clinical notes, we have here some technicalities. So in fact, we will show you the IVUS that we took. First, we will show you the complete run. Here we have the distal part of the vessel. In fact, it's more or less at the height of the third diagonal branch, the one that we didn't want to protect anyway. And here, just approximately to the distal landing zone, that is more or less 3-0, we can see a severe calcified lesion starting up to the starting down there from the mid part of the artery and going up to the left main. We will see also the left main is affected. Here we have a relatively healthy part of the vessel, and here we have an healthy part at all. It's the part at the level of that big septal branch. But before the septal branch, we have here a big chunk of calcium with a great depth because the calcium extends up to the adventitious, so a lot of calcium there. And we have here the proximal part of the LAD that is relatively healthy with a good diameter, but anyway, the calcium is over there. And we have also a little bit of that aneurysmatic part. Here you can see coming the ostial LAD that it's really diseased. In fact, we discussed a lot with Gabriele about the ostial LAD because I thought that this was a Medina 100, but in fact it seems more a Medina 110 at least. And here you can see the left main disease. So I will show you just a couple of highlights.
So again, you were talking about the left main, whether it's critical, not critical. But if you see also angiographically, the extent of the disease here of the left main, you cannot stand just the bifurcation and leave the proximal part without. There's a lot of plaque. So and the catheter, okay, 7 French, but it's dumping heavily. So I think we definitely have to think to cover the entire left main with our possible stent. So okay, you discussed with Antonio Colombo regarding predilatation, cutting balloon, and so on. But this morning, I saw this film. Of course, you prepared them better. But if you think about rotablator, you should do rotablator.
Yeah.
And here it's a young patient, so you smooth up. Definitely, I don't know whether we can really enlarge our MLA, final MLA doing rotablator. But what you can do, all these edges, which gives you hard time during your angioplasty, you can a little bit get rid of doing a burr of rotablator before. And so to make things a little bit more easier for the rest of the procedure. And after rotablator, we'll do IVUS, we do all the balloons you need. But I think we thought and we decided to do it anyhow.
Yeah, of course. And also, if we look the pooled analysis from Horizon MI and Acuity trial, we know perfectly that calcification affect negatively the outcome of the patient. So lesion preparation, it's one of the most, it's the most important part of the procedure in order to improve the outcome for the patient, and especially in this case that it's a very young patient. So now we are ready to, we advance the RotaWire using a over-the-wire system. Now we are advancing the RotaWire and we are performing, we are ready to advance a 1.5 Rotabur. Ci sei? Dynaglide.
Ashok, may I?
Yes.
Yes, Dr. Khan, can you add some comment?
Yeah, it's a fantastic case. It is a fantastic case, and I really appreciate the complexity of the case. When you want rotablation, you should do rotablation. And I see in one point in the ostial LAD, there's almost 270 degrees superficial arc of calcium. So I think it won't be expanded only by balloon.
Yes.
Just wondering and just putting up a thought that when IVUS can go very easily would you prefer to take at first 1.75 bar, or will you start with 1.5 bar?
Un po' di più.
Yes, any opinion? If the IVUS catheter goes easily,
It's not. It's
is it
not
better?
the same question I was actually trying to ask there, that whether you are taking the ratio of 0.5 or 0.6, because your rota bar should be 0.5 or 0.6, not more than that. If it is 0.7 or 0.8, that means the late luminal loss is more. After 9 months, you will see that this rota is going to be worse for this for the later. So what is the ratio you have taken? Well, you have taken around 0.5, the ratio of the rota bar.
Io farei un'altra fresata e poi
Why you have taken 1.5 bar?
Sì, sì,
So I think they will take the 1.75 later on after doing IVUS.
No, they are taking the 1.5 there too.
Now it is 1.5. So
yes.
the plan is to do the IVUS, then may upgrade the bar.
It depends on, because you know that 1.7 means the artery should be in and around 3.4 or 3.75, something like this.
Okay. Now we started to perform the rotablation in the mid LID, and now, according to the IVUS finding, we decided also to rotablate the ostium of the LID, because there is a concentric calcification at the level of the ostium of the LID.
What's your RPM for this particular case? RPM?
100.
160, 160,000.
Yeah.
Okay.
Is there any deceleration while doing the rota? While advancing the rota?
Yes, there is.
There is? So it is hard. It is very hard now.
So I think then it was also quite good that we started with a 1.5 because of course we ablated already with here something. With the 1.5, some calcium went down.
Okay.
Okay.
Yes. Okay, now we can
do a quick IVUS run.
Yeah, quick IVUS run. Now we can also exchange the wire with the standard one.
Because we don't want to go with 175.
No, I don't think so. And also we can exchange the wire, because when you decided to perform a plug debulking strategy, basically you have two different options, as we discussed it together with Professor Colombo. So the ablation systems such as rotablation and orbital atherectomy, or balloon technique. So in this case, the mechanism of action is quite different, because the rotablation just is to remove some plaque and not to modify the compliance of the vessel. So now we remove some superficial calcium with the rotablation, and we can evaluate with IVUS what we did. And in case, of course, of subintimal results, we can now go to the next step using the balloon strategy or the balloon technique, such as we discussed it before. Okay, so we are ready for the second IVUS run after rotablation. We started from the landing zone. Okay, it's important also to identify a good landing zone without disease.
Okay.
Okay.
So in fact, this distal part of the artery is more or less between 3.0 and 3.2. So I think that the vessel over there is more or less 3.25.
We have a lot of spasm now, I think, because it looked better during the first run.
Yeah, 3.5. Now it is 3.2.
Sandro, if you can show the ECG, we can also tell you that besides the spasm, there is also some flow limitation, because the patient is not suffering at all, but anyway, he has a little bit of ECG changing, not a big deal right now, but anyway, a little bit of it. But we expected it, because we did a lot of the bulking with rota, long atherectomies. So.
Great.
Have you given some nitrous there? Have you given some nitrous there? Because after sometimes you know that embolization happens.
Yeah, we are going to administer. But looking for the IVUS finding, you can see that we create some cracks. So our rotablation was quite effective in order to create some canyon and some crack into the calcium. Now we can see once again the IVUS run in order to identify the crack that we created into the calcium.
So in fact, when you are going to ablate with rotational atherectomy, those big vessels, you're always somehow worried that you are not going to crack the calcium sufficiently. But if you see here at the distal part of the vessel, the mid part of the LAD, we can see here some cracking of the deep calcium that is over there, and it means obviously here the vessel is not so huge, so 1.5 burr is enough to crack this part of the calcium. But if we move proximally, a little bit more proximally, over there in the proximal part of the LAD, we can see here that the vessel is quite huge, but anyway, the calcium is cracked anyway. So it means that probably rotablation did a good job with direct atherectomy, or even with some vibration or effect of the burr itself. And even here at the proximal part of the vessel nearby the ostium, we can see some small cracking here and here, and some changes of the plaque in the proximal part or the very ostial part of the LAD. So probably we can call it a good atherectomy. What do you think, Gabriele?
Yeah, I think so, because as I discussed, we remove some calcium with this kind of technique, but at the same time, we can also create an improvement of vessel compliance, creating this crack and this canyon inside the calcium. This could be a good result after the first rotablation. Okay. Yeah, yes, I see. Now we are advancing an over-the-wire system to remove the wire, but maybe
because we unfortunately choose a microcatheter 160, which was a little bit too long, so we have to work with this balloon. And now it's okay. It went easily before. Can we hear Antonio? Does he leave?
Let's see. Remove. So what's the comment from the panel regarding this second IVUS run? Are you satisfied, or maybe some other strategies such as non-compliant balloon or cutting balloon are still needed or not?
I think you need to repolish the calciums, the rest of the calciums a little bit after rota with a NC balloon or a scoring balloon of a bigger size, like 1:1, to make it much polished, to put the stand well opposed in the long run.
Yeah, of course. So rota is not really, it's the first, it was the first strategies, but not the final strategy.
Yep.
Yes.
Sorry to interrupt you. Please go on.
But again, if I would have need to put money on this case, I would have spent it for rota.
Yes.
Because
from Dr. Qasir Nasrullah, do you want to do the non-compliant or ballooning, or further rota then balloon?
Really excellently done the rota. I agree with you 100% that if you feel you need to do rota, you should do it. You should not hesitate to doing it. And secondly is that asking about the successful rota ablation, we can see two cracks. If there are two cracks on the opposite side, then it is successfully rota ablated. Then we can easily dilate the lesion with a non-compliant balloon and put our stent. So as we have shown in the IVUS, there are two separate cracks, almost 90 degrees apart. I think it is done successfully.
Yes.
Thank you.
So what size balloon do you prepare to pre-dilate it? 3 or 2.75?
Usually, I would like to take either 1:1 or slight bit lower, like a 3 vessel. I will take 2.75 and go in very high pressure, like 18-20.
Yes.
Then it will not perforate. So a bit low, like 0.5 low.
Any other opinion from panel, please. So Dr. Kaiser want to predilate it to 2.75 to 3.0 NC balloon, then want to extend the vessel. Any other opinion?
You like a scoring balloon here, or you will just take this NC balloon? That one is the question also.
So as rotablation is quite successful, I think NC balloon is
it's okay.
enough.
It's okay, but you know, scoring is beautiful. It's uniformly it can dilate. No balloon setting is there, so lots of positive outcomes from scoring. It doesn't matter whether
Now we can hear from Dr. Reimers. Can you tell us something regarding your strategy for pre-dilation by NC balloon or semi-complete balloon?
Yes, I think we will perform a 3.0 non-compliant balloon dilatation. You can see nicely also the left main here, how in the curve it's quite tight, no? And it needs to be addressed. And following this 3.0, we'll do an IVUS run, and then we'll use a cutting balloon. We'll decide maybe it's 325. Because we have to thank also a little bit Boston, and we get it for free today, and I think it's a good idea to use it here. Okay, in this order.
So why not upfront cutting balloon?
The step up plaque modification is the
already rota has been done.
Yeah, rota has been done, but you know, it wasn't so tight calcium. ST went quite up. It's still quite up. So we definitely ablated some material.
Yeah.
Now we prepare the plaque as good as we can. Can you tell us which size of balloon, of cutting balloon, we should use, because we want to go high pressure?
Yeah, because in the proximal part of the vessel, it's very big.
Yes. So at the level of the septal branch, the vessel is already 3.7 media to media. So the most aggressive, or the most the less conservative way of measuring the vessel itself. So 3.7 at the level of the big septal branch.
Sandro, can you magnify the pressures?
We are going to very high pressure, 22.
22.
Yeah.
Oh, we have a good cameraman today. Thank you.
Good. That's great.
We have just to wait for a few seconds to restore a good flow, and then we have also to dilate once again the ostium. But okay, we did several dilatation on the LAD, so the HEG is changing. We wait just to restore, to reduce the ischemic time, because of course this is the other aspect to consider when we decided to go with this kind of strategy, such as further balloon dilatation with non-compliant balloon. The ischemic time is longer compared, for example, if we decided to use the intravascular lithotripsy. So for this reason, we have just to wait.
Don't have any chest pain now.
Okay.
Don't have any chest pain now.
No,
he has some
no chest pain.
No, he has some uncomfort.
Okay,
but he's okay. He's smiling, but he said there's some uncomfort in his chest.
Please take care of the guide catheter, because that one is, that ostium of the left main is really dangerous.
Yeah. So you can see here it's not expanding. I'm at 28. Well, maybe, but we definitely need a cutting balloon here if we want to make it.
Yes.
I think that now we
try
can
to
also
make it bigger.
Advance the safety wire into the CERT, because now we are also approaching the distal bifurcation of the left main with the further dilatation. So it could be safer to advance also a safety wire into the CERT.
Yeah.
Because it's a big, of course, when you use a non-compliant balloon several times, there is also a lot of friction when you withdraw the system. You should be careful not to lose the wire into the main vessel. Okay, now we have this wire. Turn track. Now, I would like also to have your opinion about this ostium of the CERC. if you think according to the angio findings, if could be necessary or useful also to perform an IVUS run into the obtuse marginal in order to investigate the ostium or the presence of disease at the level of the ostium of this big obtuse marginal, because they could change the strategy of stenting of the left main.
So
I
would
think
you
it would be
just,
too much for this patient. I think
run the
too much for this
movie,
patient.
please.
It's not
Yeah,
necessary.
sure. I should. Okay.
Yes.
Thank you.
Can we have an IVUS run of SARC?
Sorry?
So
Can we have an IVUS run of SARC? SARC,
after
LCX.
ordering the SARC, do you give a IVUS run through the SARC ostium?
Okay, we can do that for you.
To plan the strategy, the IVUS in the SARC ostium is necessary.
So far, we did not plan it, but I think it's good to know how it looks like.
But anyhow, SARC is not big. That is dominant right coronary.
Yes. Yes, you are completely, but I don't want to occlude it during this morning.
So definitively, and on advantage, though the patient is 55 years, so much calcium, so it is unlikely that SARC will be totally occluded after stent from left main to LAD.
This
So
is
calcium
very right. Yes.
Okay, no need for changing the wire. This is a good crossing. It was not really difficult to cross the circ. Now, before going on, we will try to advance the IVUS. Possible concern is related to the takeoff. Exactly.
Yeah,
Unfavorable takeoff.
Yeah.
In this case, I don't want to force IVUS to be advanced because I don't want to create some iatrogenic dissection or something similar. So just to try to advance the IVUS into the proximal part of the obtuse marginal. But let's see if the probe will advance. Okay, it seems. Yeah. Okay, I think that we can start from this part. Okay.
So in fact, it's a little bit unexpected because already in that proximal, not really ostial, but proximal part of that huge marginal branch, there is a lot of disease. Here come the ostium. You can see the left main coming at 4 o'clock down there. And in fact, also the ostium
is very tight.
Yes, it's very tight. So in fact, here you can see, we will end up doing the bifurcation. You can see here, we have the proximal part of the vessel, not the really ostial part, but the proximal part. It's 3.35 of area, and coming back to the ostium, here you can see that the ostium is even tighter. So in fact, probably, let's put dynamic review. Here, the left main is coming down there, here, and we have the ostium here. And we can try to measure some type of area. It's not super precise because the ostial part of the circ is always a little bit of a challenge. But anyway, we will try to measure a little bit of this area. We can see some calcium there. And the area is more or less 3.7. Yes, you are completely right telling us that the circ is not dominant. But anyway, this marginal branch is quite big. Plus, the patient is 55, so you don't want to lose this branch, and you don't want to hamper the vascularization of the lateral wall of the left ventricle, because you can see that you look at the angio. It's quite clear now.
Yes.
Oh, it has become tighter than the previous the angiographic view.
So you need to go to the double stent strategy.
So we were talking before with Gabriele. this would have been the ideal lesion to do rotablator. It's a lot of calcium, but I don't feel to remove the wire from the LAD because it completely dissected the osteal LAD.
Yes.
To do it here, you know, the strategies with the extension, the guiding catheter extension under the wire of the LAD over the one on the circ, you could do, but here with the ostium of the left main, I do not feel to fiddle around with it.
We,
so I
we
think,
can carry the risk of ischemia.
I think we predilate
balloon.
with first with a non-compliant maybe, and then with the cutting balloon, the ostium of the circ.
Yes.
Can you live with this?
You have to do now. Nothing else you have left here.
Torna indietro. Yeah, because
Okay,
another, as Bernhard mentioned, the technique to use the guide catheter extension in order to be able to rotate a bifurcation calcification could be could be very useful because you don't carry the risk to rotate the wire into the side branch or into the main vessel. But in this case, it could be it could create some ischemia to advance guide catheter extension into this disease left main, and we don't want to have with also the right coronary artery that is still diseased. We don't have to carry this kind of risk. So it's better to leave the wire into the LAD and to perform a different strategy of plaque debulking into the circ compared to the rotational atherectomy, such as cutting balloon.
This is a 2.5 non-compliant to predilate because I don't think cutting balloon will go directly.
So if we talk about vessel size of this huge marginal, we can say that the proximal part of the vessel is more or less 3.0 by IVUS criteria. Then there is a little bit of an aneurysm, but anyway, we can discard that part. And the ostial part is more or less 3.25. So the vessel is in the range of the 3.0 vessel.
Okay.
So it's a large marginal, huh?
Yes, large marginal.
Yeah, this is a 2.0, but now we
2.5.
2.5. And regarding the
but it did
size,
not expand completely, no? I show you a little bit less.
Yeah, it's not really completely expanded. You can appreciate from this.
Let's see it now. I inflate it a little bit. Can you try to make it thinner?
Yeah, there is some waste.
Okay,
Yes.
now we go with which size of cutting balloon we can use according to the COPS
3.0.
criteria.
So
3.0 here in this, also in this vessel, I'm not sure.
yes, in fact, there is we can debate about it. Smaller and higher pressure, or a bigger and lower pressure. What do you think? What the panel thinks?
I think bigger and
smaller.
lower pressure.
I think the smaller is better for this case, especially if you take a 3, then it will be very much, it cannot accommodate the distal part. There will be a dissection age or something there in the OM up to marginal branch distally, distal to the balloon. So it's better, to take 2.7 or go for the high
smaller
pressure.
with higher pressure. Smaller 2.5 or 2.75 with higher.
2.75 is okay.
Yeah, it's quite debatable because sometimes you carry the risk using a smaller one, but with high pressure. You can create some barotrauma, but because the debulking technique is related to the action of the microblades that are mounted on the balloon. So it's not really necessary to inflate at high pressure, because sometimes if you choose a 1-to-1 ratio of balloon and artery, you can inflate without going to high pressure. And the bulking effect is related to the microblades that are mounted on the balloon. So it's debatable according to operator preference, I think.
Yes.
In this case, which kind of balloon we
surprise.
2.5 or 2.7?
2.5.
2.5.
It's better to know before inflating it.
But you can see ST came down dilating the circ. Interestingly.
So we can start going just a little bit.
It's crossing.
No, not. I would have loved to do rotablator here. Huh?
Okay, let me try once again. Yeah, and the device is quite bulky, of course.
Yeah.
So no, I think that we need some further predilatation with a bigger balloon, maybe.
It's 2.5 and we went to 24.
I think the
For me,
balloon has
this
been
is a 3/0 artery, so
For you, but for
No, three.
IVUS,
It's also
it's
3/0.
It's 295.
3/0.
Yes, okay.
A little less.
it is crossed.
No, I don't think so. Let's make a very small test. I don't think no test necessary.
No, because
Okay.
Yes, crossed.
Yes, finally it's crossed. So we can start from this part.
Very good.
And then going down.
So in fact, in our experience, we know that cutting
indietro.
balloon, even this new generation
No,
Wolverine
sono
cutting
18
balloon
dopo.
is a little bit bulkier and a little bit more aggressive than scoring balloon. But in our cut lab, we decided to take or to keep only cutting without scoring balloons, because we believe that dissection is not a big deal if you're able to face the dissection with drug-eluting stents. So
How
we
much
decided
pressure
to
you were?
yes.
Sandro?
Still there is OHing.
Yeah,
Less.
24?
Less.
we can deflate and then inflate once again. Sometimes you can achieve a complete expansion of the balloon after 2 or 3 inflation.
And you rotate 90 degrees
Yeah, in
so
order
you
to-
cut, but no, okay. You
modify
will
the-
not know. Okay, negative, a little bit ahead, I would say. A little
Yeah,
up.
you have to beat it again and again.
Yeah.
Vai, vuoi andare dove?
Giù.
Okay.
It's crossing more easily now?
Yes.
Okay, this is
sì.
also a good sign, because despite being used at 24 atmospheres,
I think a nodular calcification is there
Metti
focally, and
15,
that one is
vediamo meglio.
creating problem.
io andrei anche con la calcificazione un po' più a valle,
Sì.
no? Wow. It's good. It's good. Okay.
Okay.
Here I go a little less.
No, that is down.
Yeah. But we saw a lot of calcium also there. Here I get less pressure. Okay.
Mi fai la collimazione, Robby, un po'?
This is the exact site. Yeah.
This is the point, no?
Yes. Distal part of the balloon is in that lesion.
26, I don't trust any higher. Okay,
Oh.
negative. I think rated balloon burst pressure is
I don't believe in this.
it's
in the range.
around 12.
Inflate.
So we just doubled it.
Vai, vai.
But we'll go with the 3.0 on the LAD and the left main, I think.
Okay, now. Okay, now
Can we a drop of contrast? No, you don't.
you are
like.
the chief of the Cath lab, so
No,
if you
okay,
want
it
some
does not cost
contrast,
so much. But you can also,
I'm not really a fan of contrast.
then let's
but,
do the cutting on the LAD with the 3.0.
he is my chief, so
No,
I have to.
I'm not your
Okay, just a little
I'm
bit
happy
of
that I'm
contrast.
still able to get the devices on the wire from behind.
Okay, let me check the best projection.
It was nice. The one was nice.
Yes, but I don't remember exactly the. Okay, this one, 18 and 40.
So it's after cutting balloon, it's the picture is like this.
No.
Not
Before.
Before
Can I have a
I was sorry, I was looking for the same projection in order to have the same information. And aspetta che
Dobbiamo riempire.
check. Okay.
That is very important. In the same projection, how the lesion looks. That is very
Vediamo anche il
important.
distale che non vorrei ci fosse un buco.
Because
Metti per sbaglio, guarda la
a lot of dissection in the left main also.
Vai.
Yeah, it's incessant calcium.
It's look better, but maybe we have to do some work.
Do you have, can you take another picture in different angle to see actually what is LCX actually? Because it's, see, sometimes in the yellow caudal view or somewhere you can get
This
a
was
better
left
picture.
caudal. Now we try right caudal a little bit. Let's
Yeah.
see. Prova questa. Vedi?
I'm not really sure that we can
Piccolo,
identify the
No,
calcium.
No,
Yeah,
we
not
have to go
that,
real
but
as a
it's not-
spider.
Yeah,
go
Yeah,
much
because
spider.
we tried
Spider without hitting the cameraman, yes.
I think that the previous one was the only one in which we can appreciate the
Because here I have
bifurcation.
this.
Test at least.
That is the best, yes.
I tried to get the LAD on the
But
other side.
what is the added value of this angel? I don't know. I don't understand. We have the
If you have to
imaging.
stand.
Yeah, but
if you
I
have
think
to do
that
two
DK
center
crush is the
technique.
best strategy now.
I
here.
suppose so too.
So check. But
No,
okay,
this doesn't give us anything.
The only one, it was this one. It was the only projection in which we can appreciate the bifurcation. So before going on with the stent, of course, we have to decide if we done a right job into the ostium of the circ, because of course now we are treating this this part of the artery. So if we think that we are quite satisfied of the result that we achieved with the cutting, we can go on stenting the mid part of the LAD and then to go on with the
We still have to do the
technique.
cutting on the LAD with the 3.0.
Yeah, but what about the ostium of the circ? We are satisfied.
To go for stenting. But still, again, we cannot do rotablator anymore.
About the opinion from the panel regarding L6 ostium, are you satisfied with the predilatation?
Yeah, that deflected 2.5 balloon, if it's processed easily, then you can stent it. I think the deflected cutting balloon was crossing easily.
Okay, now he has having a little bit more discomfort and there's tears going down.
Yeah.
So he
now,
likes
okay, we can stent the mid part of the LAD, and before stenting, we perform just a further dilatation with the cutting balloon into the LAD, and then we can deploy the stent.
Okay. Guarda la guida, guarda la guida.
Okay.
What is the size of the cutting balloon for the LAD now?
Sorry?
3.0 now.
No, va bene.
What is the cutting balloon size for LAD?
The balloon size, which is this
3.0.
3.0, yeah, according to the.
Because we have the other side is also in back order.
Era tutto aperto.
There is some staining, you can see, so there is some. Oh, okay. We have distal and diagonal perforation, something.
No, the diagonal, I think that it's a
Staining.
dissection, but distally it's a perforation.
So did we do ACT? ACT is what?
I think
more or less 250.
250. Okay, it was 236 and we gave some more. Here we won't exaggerate, no, just open up this dissection. Okay.
what's the staining at the apex, close to the apex? There is
yes.
persistent staining of.
Yeah,
maybe it's a small perforation.
yeah. Now we check.
The wire was a little down for a while. We have to the ostium of the left main, sorry, and the left main. Ok, fuori ancora uno.
Indietro.
Sì, perfetto. Perfetto. Here we are in the middle of the ostium of the LAD, of the left main, you can see, no?
Perché l'IVUS? Perché l'eco?
Ho fatto solo portamento.
Ah,
ok. 1 second.
Cazzo, mentre gonfiamo il PC.
Sì, ho smesso.
Ma adesso non posso vedere.
Adesso sì.
No.
Adesso sì.
Okay. Facciamo respirare. Ok.
Okay, now we let him
not
breathe
really,
a little.
I'm not really worried about the distal staining because it's a staining. So it was worse if
it disappears.
Yeah. I think that it's intramyocardial.
So
yeah.
Yes. Okay. So that is less dangerous than the rapidly if it fade away. That is dangerous.
Okay, there is no
send
flow
no
into
flow
the
is there.
LEDs. Okay, now can you
You
give
have
us
to
a
address
stent?
the
3038 stent, please.
3038.
338 stent
Time for a
Ultimaster
stent.
before.
So
3038.
you have to address the LED very
Dammi
quickly.
l'ultimaster, vado. Yeah.
ACT was a bit low, 250 or
No, what is the ACT value? Because we
Was-
have an
it was
internal protocol, so the
250.
nurse check for the ACT by herself. So we are no worried about the ACT value because we have a Cath lab protocol because we have also a CTO program. So all the staff nurses are used to check the ACT, and they also add some heparin according to the finding.
Without disturbing us. Well, it
that's-
doesn't disturb, but you know, we are distracted. Sometimes I think the wire, yes, I keep.
Presentation of lesion preparation. My question is, there's a relationship actually, drug delivery from stent and polymer disruption in case of this type of calcification lesion.
Good.
So which type of
I
stent
think we go.
do you
now.
want to use, and which would be the preferred stent in this type of lesion? Anybody can say?
Yeah,
Okay.
this is we are using a Ultimaster Tansei that it's an evolution of the previous Ultimaster stent. It's some added values such as a modified tip and also reinforced shaft. So it's a very good device, and also the deliverability and the trackability of this device. It's very good. So
I think the LED flow has been restored here.
We don't know yet, but
small.
okay,
Small amount.
38 could be
Don't take
another
it.
choice. Okay,
Yeah.
We need another 38 at least. Probably can.
yeah, I think
put a
that
couple, no?
before going on, we have also to check if the stent was able to restore the antegrade flow into the LED. That is the most important thing, because so in this case we can work without any hurry on the bifurcation.
Yeah.
Oh, great.
Okay.
Yes.
Yeah, great.
Okay.
So check now for the distal finding. No, I think that there are no perforation because before going on, I prefer to take.
It was a
picture.
staining because of the
staining.
proximal occlusion, no? In the apex, I
In
suppose.
fact, Sandro, you can show the
Okay, no
polygraph. In
perforation.
fact, yes, the polygraph is the pressure is very nice. The
Yeah, I think that
yes.
Bernhard is right. The staining was related to the no flow into the artery, so no flow.
And I think I'm now very happy that we did also rotablate everything, because in this little upsetting situation, it was good that we got the stent so relatively easily down, and this is definitely also due to the rotablator.
And also another interesting aspect that all the side branches are still open. Okay, there is some slow flow into in one septal, but the diagonal branch are still open. So it's important also to.
So what I would do, I would
now we have to go to the
put another.
We have to.
We can wait because we need to put another stent in the LED and then LED left main.
Yes.
We cannot do it with one stent.
No, I think that now we have to deliver 3.5 into the proximal LED and then a 4.0.
Yeah.
A 4.0
and then we have to
DK crash.
decide. Maybe Antonio, have you got an idea? The strategy for the bifurcation.
Which bifurcation? The
left main bifurcation.
Or
because
I will do everything possible not to stent the circumflex.
Look,
because it's better to avoid. If you really
have
cannot,
you seen the ostium here?
Yeah, if you cannot, you have to stent, of course. But usually the recurrence rate of the ostium of the circumflex is high. So I do only if it's really needed.
And
I will predilate the circumflex with a trio cutting balloon high pressure.
We
trio.
Trio.
No, we did with 2.
No, we did according with to 24 atmospheres. It was 295 with a 2.5. to 30 to
Right.
24 atmosphere.
Okay, 2.5. And what is the result after pre-dilatation?
This one.
Not better,
I will try a 3O. I
We
think
have.
a 3O.
but the used one will not cross. We need a new one.
The 3O 2.5, 3O cutting balloon. You need to have a little bit of dissection. There is no dissection there. So
Okay.
you need to have, but if otherwise you implant a stent, but I will try not. to.
Yeah, but
I will do another attempt with the 3O cutting.
okay.
Ci dato
Maybe
cutting
without going at
309.
20 atmosphere, just going 15, 16. 3O cutting, and then decide.
So
Yes.
that's
Please,
that's
please.
very important if the LCX ostium is not dissected. So it is not properly pre-dilated for the stent.
Exactly, exactly, exactly. Angioplasty means dissection in these patients. If you don't have
Yeah.
dissections,
Thank you, sir.
you
This
don't
is
do angioplasty.
very good advice and very good.
Thank you, Prof.
Aspetta, qual è la guida verde?
Quella giusta.
È
sia
preso.
complessa,
Colombo.
quella più lunga è verde.
Ok, hai messo un bottone.
Dr. Reimer,
Io no.
Dottor Reimers ti stanno chiamando.
Yes,
Prof, scusi, Prof, ci siamo incastrati.
yes.
can you bring Colombo again? Because, you know, he is already attend BSI program
Hmm?
several times. So I think
Agli 2000?
he can understand the BSI taste and flavor, and he can answer
No, vai
very
a testa.
nicely. And BSI
Yes.
always appreciate his effort, always appreciate Colombo.
Yes,
Especially
yes,
our
of course.
President, Professor Akram Fazlur Rahman, sir.
Okay.
He's
Eh,
our
dai,
new
un attimo
fellow, isn't
il
it,
microfono,
Bernhard?
Colombo.
He's our new fellow, Antonio
No,
Colombo.
he is such an enrichment, as you can imagine, for us.
Actually,
So we are, okay, it was a new cutting balloon because I think it was
Hello.
useless to
Yes,
try.
yes.
Maybe, okay,
Okay, stay, yeah.
you can ask
Okay.
all the questions.
Yeah. So this is a 3O cutting.
Yes, I go to 20, not more.
Okay, 20, no more. Okay, it's a good size.
Yeah,
It's
now
well,
it
So
it's well
when
open
you
now.
inflate a big balloon, the stressful moment is when you deflate the balloon. Until the balloon is
Facciamo anche
inflated, there's
25
nothing.
come prima, o no?
Sì, ma no, ma abbiamo già fatto.
Ok,
Okay.
vengo un po' più indietro.
He is experienced quite pain when we dilate. Facciamo un altro po' di ipno.
Okay.
L'ipno.
So now we can also check with IVUS
Allora no.
to check for dissection.
There is a lot of
po' di-
recoil in the left main because it's always ventricularized
un po'
with the
agitato,
guiding
stazione.
cath.
Yes.
Ok, facciamo l'IVUS.
I think we have to carry on. We do the IVUS or
I would do an angiogram to
angiogram, I
see if
think.
there is an improvement.
Yes, I like this projection.
Do a nice
Metti
feeling.
15 robe. È un po' di sedazione, Ale.
Okay.
It's a little bit better. It's a little bit
now
better.
it is dissected. Now it is
There is a
dissected.
dissection.
Yeah. So now we can do provisional. We have to carry on because the
Yeah.
left main is very,
Yeah.
and the patient is.
Yeah.
So we stand the
I
LAD
think you
and the
can
left
stand
main,
the
and then
left
we
main
address it,
anyway.
and we
You
do
can stand the
provisional.
left
Okay.
main.
Un po' di
I would
sedazione,
stand the
Ale.
left main, so we
no,
go
I
away
was-
from this
no, I was-
ventricularization, and then you concentrate on the circumflex.
Exactly, because ECG is not good. So long ECG was very fine. Now there is gross ST depression.
Yes.
Left main,
And
nice
we get the
stenting,
catheter a little
and
back,
then,
so he can breathe
kissing
also a little
balloon on the
better.
circumflex,
Attento, Dam.
left main,
Attento,
and
Dam.
then if I like personally to measure the gradient in
stand
the
strategy?
circumflex.
Sorry?
So now provisional left main to LAD.
No,
Yeah,
now we
no,
are advancing at
provisional left main to
3.5,
circumflex.
18
I mean,
stent into the proximal part of the LAD. And finally, we will use a two-stent strategy for the bifurcation of the left.
We use a blood
Me-
coated balloon in
Well, provisional.
Bangladesh.
Why provisional? I don't like
Yeah, we
provisional
have
because it's,
we have
it's, still,
inverted.
it's already
In
dissected.
what the
Yeah,
name?
that's because
With the paclitaxel reaching
provisional stenting in the left main, it's not
Invatec.
really the most effective
Invatec,
technique
Invatec, yeah,
because
yeah.
you have to
Now
perform the
it's
tap
Medtronic. It's good.
or
it's
which kind?
good.
The culotte?
We did a study with
it's
that
a
balloon.
Medtronic. Yeah.
We did the Bello study. It's a paclitaxel, but very effective, very effective. It's one of the best. It's old, but still very good.
Yeah, we know that you like the DEBs very much.
Yeah, I think for distal lesion,
Okay.
for this kind of
Good.
things, it's okay. But to use DAB, you need to learn how to do angioplasty and not just stenting. New generation don't do angioplasty anymore.
And now we put it this balloon up to the left main, and we'll see.
Damiano, prendi un po' qui.
Vediamo una misura.
Non so se ci aiuta, ma
Allora, metti... ma cosa è successo?
ho fatto
Ah, mosso il braccio.
un po' indietro, abbastanza indietro.
Deve stare fermo, Marco, se no è un problema. Fai un mezzo cc di contrasto per vedere.
No, scrivete che la...
È ancora lungo, eh?
Sì.
28, sono 18, 28, no? Fai
So
un
it's
film,
a
piccolo film,
318 stent you have?
piccolo film.
Ok.
Damiano, do you with us? Damiano?
Sorry? I
It's a
didn't.
318 stent?
Can you-
It's a
can you-
318 there?
So we are going. We are just implanted a 3.5 18 Ultimaster stent in the proximal LAD, and now we are sizing with the balloon up to
So
the
I think-
ostium of the left main.
I
Yes,
think
we
you
are
need
going.
another 38.
Yes, more or less, probably. Surely more
Yeah.
than 28. Probably 38 is the right size.
38 is would be better because you have to go to the ostium, and so
Yes,
you better to
yes.
have a longer stand rather than a shorter stand.
Yes, plus we don't have to forget that in that part the vessel is more than 4.5. So if we leave a little bit of overlap or excessive overlap, is not a super deal.
Questo è non compliante.
18, no, questo è lo stand.
Dammi un 3 non compliante.
Ma ci passa.
রিপোর্ট চিকিৎসা দিন না মানুষের চিকিৎসা দেয় মানুষের
You
কথা
have
বলেন।
438 in your shelf.
Compliante è un 2,75 stent lungo 24.
So can you see, there is some other people, can you see the dissection of the circ where the wire is completely above the vessel? Can you see?
Yeah, it's
And this we cannot leave. We will never be able to rewire this. Now we have to do a decay crush. Do you agree?
That is
Quindi
a
ci-
set,
Better now,
that is a set
better
plan.
now.
Decay crash is a
Yes.
set plan for this patient.
Sì.
Yes, so we selected to do decay
Esatto.
crash for the reason
No.
that you already showed us. You told us, and you're completely right, that probably the rewiring and dilation and re-stenting of the circ would have been a nightmare or nightmarish. So we decided to stent the circ first. So we will go with the decay crash.
How much you would go with the stand up to the LCX in the OM branch, because you have disease also beyond that bifurcation.
Yes.
How long stand you will take, because the stand to take the stand is will be a little bit cumbersome for you if a longer stand you take in LCX.
24 for the circ.
Yeah,
I
that's
think that
okay.
it's enough.
I think not more than that.
Yeah.
24 is enough. Yeah, that's good. So that is 324. Yeah.
It's a
At
2.75.
2.75.
Yeah, because we don't want to carry the risk to dissect the proximal part of the circ, and then we can
Well,
post dilate.
dissect more than this.
No, the proximal, not the
Okay.
ostium. So maybe the
Which is not so big, yes.
advancing a trio would be too big for the
distal. Yeah,
Yeah.
distal.
Yeah, also you have to
parola
remember the
anchoring.
Finnett's law. That
Gonfia
Finnett's
il
law is
pallone
not
nell'IVA.
permitting that.
No.
Pallone nell'IVA. Il pallone nell'IVA è questo.
Okay.
Tu l'hai aperto questo.
So in
No,
order
questo
to
è
bring
giusto.
down the
Questo è il
stand
pallone.
over that bad angle, we
Ok, vai
anchored
giù col
a
pallone.
Yeah,
balloon.
it has done. It has been.
Yes, we anchored the balloon on the LED, the stand crossed. So right
Yeah,
now
this
we
is
can
very
work.
useful when you
Yes.
perform the decay crash to use the balloon for the anchoring. Now I need some check to check
Okay,
the position, the protrusion of the strands. Now I have to go.
There is
a
some
little bit
staining
more.
there.
Yeah, sure, I know, because there is a section, so it's quite expected. Check, please.
No, some more.
Okay.
Okay, I think
Deliver
this
the
is
stand.
yes. Stand, I go.
Stand. Yeah.
14.
So how 14 here? So that is the same instant Ultimaster.
Yeah,
Yes.
this is an Ultimaster Tansei 2.75. Aspetta, Rob. 24. Usually in this case, I prefer to remove the wire before crashing in order to avoid some entrapment of the wire. And I remove the wire because, of course, we have to rewire after crashing.
Yes.
Yeah, because wire has been too much kinked there.
What is the
Okay.
balloon in the
I
LED?
go.
3.
3O non-compliant balloon to crash the stand. We can also perform a stand boost to check for the right crashing of the stand. Okay, we crashed.
You can go a little bit.
Yeah, there is some noise due to the previous implanted stand. Okay,
Yes, we go a little
inflate once
back
again.
just for safety.
Yeah,
This didn't help us.
but we create some good crash. Maybe we have to use a bigger balloon to crash it better.
But I went very high up.
Okay. Down.
Let's
So
see whether
Sandro,
the balloon.
Now we have to
can you show
recross.
the HG that just came back because in fact he suffered on the circ side this time. So
more than on the LED.
More
this
than
time.
on the LED. So it showed that the importance of this large marginal despite the right dominancy. In fact, the decision to stand the marginal was, I think, inevitable. Obviously, we always prefer to avoid stanting of the circ, ostial circ especially. But anyway, if you need it, you need it. And then this time probably the patient would have needed.
Vabbè, tiri fuori tutto.
No, questa è quella dell'IVA.
Vabbè, è già fuori.
No, quella dell'IVA è ancora dentro. Vabbè. Okay, now we have some problem because of course we inflated very high pressure, the non-compliant balloon, and now it's the friction.
Incarcerated,
yeah.
yes.
So I have to re-advance the wire into the LED, no problem at all, because it's already stanted. So I advance the wire into the LED, okay. And then I can remove it, all the system, the non-compliant balloon with the wire.
Yeah, sometimes it becomes stuck.
Yeah, exactly. When you inflate a non-compliant balloons for several times. Now I need another wire for the recross. I prefer to use the Sion Black. When I have to recross the crashed side branch, my preferred wire is a polymeric one. So the Sion Black, it's very effective to recross the side branch, the crashed side branch in this case. And also we can also make a small check to check for the integrity, for the patency of the circ distal to the stand. So good. Maybe some spasm, but I think that the circ it's open now, and also the HEG is becoming better. Okay.
So okay, so if we move back to baseline IVUS, going from Sandro, if we can show it while Gabriele is rewiring the circ, because obviously Gabriele will need a couple of minutes. We hope no more than a couple of minutes, but anyway. Yes. Okay. Here you are. If we go to the baseline IVUS, according to our baseline measures, we can see that from distal landing zone to left main ostium, the length of the lesion was more or less 85 millimeters. So we already implanted 38 and then added 20. So we are more or less at 58. So it's completely reasonable that we will have to add another 38 millimeter of stent. So probably you are completely right about the sizing and the length of the stent that we will need. Now the Sion Black went down, and Gabriele and Bernhard will do the first kissing. Am I right?
Yes, I think we need a 1.5.
No, I try to 2-0, 2-0.
Okay, you're
I'm
more...
quite optimistic now.
Okay. 2-0, semicompliante.
Nuovo, però.
Nuovo.
Okay.
Sì.
Okay. 3-0.
So it's our routine here in our Cath lab not to be super aggressive on the first kissing,
Yes.
because obviously you need it in order to optimize the carina, you need it in order to facilitate the second kissing. But anyway, we tend not to waste too much time doing an aggressive first kissing with non-compliance and everything. We try to go quite fast with semi-compliant balloon, and then to spend every hour resources on the second kissing that is the most important, and you need the non-compliant. What do you think here there in the panel?
Now, how much you are meticulous about this textbook approach of proximal strut rewiring or middle strut rewiring?
So, Dr. Gabriela, we are.
How much you are meticulous about this proximal strut rewiring or the mid strut rewiring for this?
You are happy when it goes down.
Yeah, no, okay. No, okay. It's not always the right.
Yeah, that's what I'm telling.
No, I mean,
practically in real world, it's really hard.
In the decay, you should. You should be quite meticulous. I mean, it's better. Okay. Inflate, please, questo.
So you know that
now I am performing once again the distal anchoring to try to have more support to cross the struts with the two. Okay, it crossed.
Yeah,
I think.
Okay, wire.
Yeah, let me check for the wire. Aspetta, dov'è la guida? Okay, this one.
Perché li hai cambiato adesso le due. Sto spingendo giù l'altra.
It's not crossed. It's not crossed. So maybe I have to there is a prolapse. Yeah, there is a prolapse. A prolapse of the wire into the LID.
A long one, yes.
Yeah.
I think.
Okay, I try once again. Yeah. And then if it doesn't work, I change with a small balloon. I mean, gonfi il 3 per favore.
So anchoring in the distal stent of the LAD.
No, there is some
it's prolapsing here.
So it's better to use a low profile balloon now. Down with the balloon. 1.5.
Rui Ray 1.2.
I think this is the most challenging steps to positioning balloon, right?
Right.
Yes.
Yeah, but as said, Manos Brilakis is a brilliant editorial. DK crash, no pain, no gain. So you have to.
Yeah, that's true.
Yeah.
Can you take?
Yeah, I know that there are other bifurcation stenting techniques that are quicker, but I think that, in my opinion, for the left main, decay crash is the once you decided to go with the two stent technique, decay crash is the most reliable for the patient in terms of outcome. Yes, and safety, of course. Aspetta, Robby. In this case, gonfia il pallone nell'IVA. In this case, also the takeoff of the circ, it's quite unfavorable. Okay, okay, down. Vai Bernhard, don't get far. This is a 1.5 balloon.
That was. No, it still is. Not dropped at 24.
Non so se abbiamo dilatato le maglie. No, c'è dentro due robe, ma così non ho dilatato le maglie. Perché era corto.
No, no,
There is
era
crossing again.
monomarca.
Ah, ok, quindi
Aveva solo un
perfetto.
marco.
Ok, now we can try to advance the 2.0. We create some space, we hope.
If it looks already still nice, the 2.0. Because it was a little bit. Well, no.
Sì, però non l'abbiamo mai gonfiato. Now the ECG is normal. The patient is quite is suffering from some discomfort, but related
Also,
to the length of the procedure now.
And
He's quite tired.
He does not react nicely to Valium, so we cannot give too much.
So this is actually a very complex calcified lesion, rotablation, cutting balloons. So it is 1.5 hours we are passing. So that is not prolonged procedure.
Can you take a note?
Più corto, questo si piega.
We are approaching our time, so I think we are
l'1,5 si è rotto a valle delle maglie.
No.
Io ho questa
Ma
impressione.
non si era rotto alla fine.
Sorry,
No,
we
no,
didn't catch
sì, ma allora non
the
ho mai
question.
dilatato attraverso
Allora
le
lo
mani.
usiamo.
Dammi un 2 più corto.
Un 2, perfetto.
Dai, dammi un
2
2 di 10. Golam, I don't know if time is running. I don't know.
Time
Yes,
is
we have-
running, but we can allow you 10 minutes more. I think next section, the people already.
We apologize for that.
Okay.
No, this is for the
Great case, actually.
itself.
Great case.
The case itself is very much.
You don't apologize. I should apologize because I have to engage a lot of people. So I think wonderful case. It is a really great case and really cheap case actually. Complex iris indicated.
Oh, great.
You did a lot of steps. You go for lesion, adequately prepared the lesion by doing your pre-dilatation, rotablation, cutting balloon, as well as NC balloon. Then you go for stenting. Then you face some complications and you're tackling nicely. So we have to with you 10 more minutes. I think.
Okay,
it's
thank
okay.
you. Thank you for giving us this opportunity. Okay, now we were sgonfia, Robbie. Now, thanks to the trapping, to the anchoring, we were able to advance the balloon distally. And now we can perform the kissing, the first kissing. You can use also the stent boost. Okay.
Ma questi sono tutti non si danno neanche.
Un altro.
I want to advance just a little bit more. Okay, good.
Yeah.
One is short and because it kinked the 15. Now my one is broken, the circle balloon.
Yeah, I think that now we can perform we can deliver the second stent.
I believe you did a great job because you overcome the most challenging part of this.
Io prenderei 28 minimo.
38.
Okay.
No, abbiamo messo 18 e mezzo.
Mi serve 38.
Lo stesso? Ok, 38.
Okay, now we can go on with the stent into the main vessel.
Should be 3.5 or 4 into a 38.
Sorry?
What
What
will
will
be
be
are you putting for the left man? Is it 3.5?
No,
4038. 4038.
Okay.
And then you plan to post dilate with 4.5?
Yeah, of course. After the deployment of the stent, we have to perform the first pot, the second kissing, and the final pot. And after that, the final post dilatation, maybe with a 5
You have to tell me which one is the wire, because I got
according to IVUS media to media, left main is 4.70, 4.7. So I don't think that we have to push up to 5.0 because there is a lot of calcium there. You can take some risk to break the vessel there. Probably 4.5 at high pressure would be a better choice, but we will discuss with you the choice of the pot.
Yes, thank you.
Maybe in the next 7 minutes, like the final of the European Champions League. We try to show you the final result after the stent deployment, and then if we finish the time for the connection, we will go on with the final step of course, the decay
And
crash and stent
We hope
optimization.
that Italy will win, yeah?
We hope. Okay. So you can appreciate that this kind of stent was advanced very easily because of thanks to the plaque modification.
What about your L6 wire?
That is removed, I think.
No, it's still there, the L6 wire.
Io la rimuovo la bilanciatrice.
But we
Fai
get
un check del tronco.
So at the end, the panel suggested 38, and 38 was the right the right length. Probably 33 will be slightly enough, but I don't think 38 is perfect.
I do want to do a film because you're a lot out in the water.
No, we have to be sure where to deliver the stent. We are outside.
Yeah, we can go another 5
5
millimeters inside,
so.
but
So it is AP40 view?
this is left cranial, yes. A
That
little bit
seems
more
fine.
outside.
This is very crucial to adjust.
I think I like. We like?
Yeah, I like.
Yeah, the better place, best place, yeah.
And well, 33 would have been short. I agree.
So it was quite a long left main. Huh?
Yeah. And big.
Wow, the expansion of the balloon of the stent seems quite nice. What do you think, Bernhard?
Yeah, it was quite high atmospheres.
Plus, we did a lot of calcium in the bulking, so more than this.
It is more uniform.
No, there was a lot of.
Abbiamo messo l'ultimo stent. Quindi adesso
there was a lot of disease. The
I
vessel
used
was
the
much
balloon
bigger than
to
we saw.
advance. I used the balloon to advance the guide catheter in order to not to
distort the
to deform the
platform.
yes.
Yeah.
So we do have to use pot with which kind of
Give
balloon?
me the balloon for the
4.5. We just check whether we need the 4.5 to do the pot, and then we rewire.
Okay, give me the balloon, please. For the pot.
Yes. I think we do 4.5. Non-compliant 4.5. Non-compliant 4.5 we start with, and then
with a small one or a bigger one.
Let's see the left main. He's just checking the IVUS. Can we see the IVUS?
15 or 10. You take 15 or 10.
Okay, in this case we can also use 15 because
15
we have
you
enough
can use
space.
because
yes.
the time will be less.
It's according to the availability in our catalog of the 4, 5, 15.
4.5 non-compliante 15. Yes, but you can go as much as you want in the aorta, so you don't need a short one. Yes.
It's a long left main, so we have enough space to perform the pot.
And don't forget that we have to
15 is okay.
Even before the final kissing.
Yeah, but also in this case, the pot it's okay incorporated into the technique, the first pot. But if we cover the ostium of the left main and also we are guiding catheter, we don't carry any risk to go under the struts. So it's not in this case, in this specific case, it could be a skip. But okay, we would like to do the technique in the best way. Okay, let me check for the carina now. Okay, it's a very long left main.
Yeah, but we have to postulate also distal a little bit. Huh?
Yeah.
Because it's huge. You can go also more distal. And then we do the pot as high pressure.
Yes. Okay.
Proximal LAD is more or less the same diameter.
Dot is very much important. Dot, then pot. First, you have to do the dot.
Yes. I don't know whether you can do it with the same balloon, but we vary on the pressure. You have to get practical, even because it's noon here very soon.
Yes, plus.
Okay, Osteo.
Sì, sì. Mi dai di nuovo l'azione black, per favore? Dammi un altro. Oh.
Era molto morta.
Let's show
Okay,
them.
now, I don't know, we have 2 minutes.
I
no
don't
more.
know whether
can...
we are really in the order. Let's make this safety inflation. Thank you.
Okay, we can also do an angel just to show you the final result before the final optimization.
Yeah.
And then you watch us if we can. If we are able to wire, we'll be able to kiss.
Yes, of course.
Exactly. So
how much pressure did you inflict the purport? 18?
No, I think the pot at least 24.
yes,
because vessel was 4.6 by 4.9.
You mean the pressure?
Diameter,
you
yes.
mean the pressure? Yeah,
Yes.
I usually like to perform at high pressure the pot.
24.
Because,
but you want to?
I would like to rewire and then to take the angel.
Okay, if you have time.
Yeah, 2 minutes or more. 1 minute. And
So
then I'll show. Okay, we are trying to advance the IVUS into the circ. I think that it. Are you able? Oh,
yes.
Mr. Kamru,
Great.
can you make it bigger screen?
Okay.
No, okay. Now we are going to try to advance the IVUS into the circ, and then we will try to show the findings and what we did. Because we are already finished all the step of the decay crash that we are going to show you. We did also an IVUS evaluation of the LED, and before ending, we are trying to advance the IVUS to check the ostium of the circ.
Okay, pull back.
So,
Circ is not so big here, but it's 275. He post dilated with a 3.0. Okay, and here we are in the left main. You can see the wire, the two wires. And let's evaluate.
yeah, because Bernhard has some concern about the need to perform
We
another
use a
post-dilatation.
3.0 non-compliant balloon ostium of the circ at I think at least 20 atmospheres.
Yes.
Okay, now just to show the final step, and then we can decide if it's needed to go on with the. Okay, this was the last picture that we took before. Okay.
Can you show the final picture?
Yeah. Okay, I was showing you. Okay, so this is the final picture that we took together with you 15 minutes ago. After that, we recrossed the circ, of course, per the second kissing. This was a cyan blue, so we crossed it. Then, before performing kissing, we advanced at 3.25 non-compliant balloon to perform the post-dilatation of the first tent that we deployed on the LED, in the mid part of the LED. So this is all the post-dilatation. So this is the advancement of the balloon, non-compliant balloon 3.0 into the circ. We perform the kissing. You can see here the kissing with the 3.0 into the circ at 3.25 into the LED at 14 atmosphere for both balloon. Then we perform a pot with a 4.5 balloon into the left main, several post-dilatation. This is the 4.5 at the level also at the ostium. And then we did IVUS once again. And Damiano, will you show you the IVUS finding of the second run?
So this is the final IVUS of the LED system and the left main. This is the distal edge of the stent, well opposed. The area over there is more or less 7.6 square millimeters. So a good area considering that is a 3.0 stent post-dilated with a 3.25. So here we are approximating to a region where there is some minor malapposition over here. You can see here some minor malposition. We decided to further post-dilate this part with a 3.75 non-compliant that Bernhard and Gabriele are doing just right now while we are talking. And this is the proximal LAD that is really well opposed. There is the part with the 3.5 and then the 4.0 non-compliant 4.0 stent and then non-compliant balloons. And here we are coming up to the proximal and ostial LAD. You can see here the LAD ostium that is quite fine. So I think that we are able to yes. Then the circ is coming, and this is the left main. Let me tell you that the left main MSA is more or less 16 square millimeters. So I think that even in prognostic terms, we did a good apposition of the stent there. And here you can see that the real ostium is completely covered, is fully covered by the stent itself. So we were quite satisfied. This is the MSA. Then
one thing, Damiano, can you tell me what was the MLA in polygon of confluence on LED ostium or L6 ostium?
Yes, so baseline circ ostium was 3.6. Baseline LAD ostium was more or less 4.5. So not completely critical, talking about IVUS criteria, but anyway, it was relatively super diseased because the vessel afterwards was about 4.5 millimeter. And here is the LAD ostium, MSA. So we talk about a baseline MLA of 4.6 and a final MSA of more or less 15 square millimeters. So more than 3 times the baseline
I think that's
area.
great. That's great.
Yeah, now we can go on this, the angio. Bernhard decided, according to the IVUS finding, to perform another post-dilatation of the ostium of the circ, advancing at 3.5 ballooning, isn't it?
No,
Bernhard?
it's 3.0, just we went to 28 atmospheres. It's not bigger than a 3.0.
So I think that...
Okay, it broke this one, so we have to do with another one, the kissing, uno uguale. Oops, what was better?
Dr. Khan, are you with us? Dr. Kassan Khan?
Here you have to keep the wires really because of high pressure.
So I think that if we consider the baseline angio, I think that all the effort that we did was finally successful in order to offer to the patient the best strategy in terms of percutaneous revascularization, because it's very important to achieve the best outcome as possible for this patient, because it's a very young patient with a strong indication with the surgery, and he refused the surgery. So I think that all the effort that we did was finally successful. And also thanks
I appreciate your report, and finally going to close our session. Before going to close our session, I just want to know one question, quick question. What was your antiplatelet strategy in this patient?
Oh, good question. So
because it is a complex procedure, right?
Yeah, I think that 1 year of dual antiplatelet therapy could be
1 hour
could be our strategy, because of course you have to decide according to different anatomic situation and different patients. So in this case, 1 year of dual antiplatelet therapy could be the best solution in case of good tolerance for the patient. But
in your cath lab, do you practice precise depth score to decide to continue your DAPT strategy or depth score? Because you know, if you continue 1 year, then you go for further than depth score.
Sorry, Golam, but I cannot hear you.
I want to know you actually in pre-procedure, do you go for precise depth score, DAPT score, precise DAPT score.
So we don't do it routinely. In
Yeah.
fact, we usually do it for elderly patients. We are talking. We don't have to forget that this time we are talking about a 55-year-old male without diabetes, without kidney disease. So probably the precise DAPT score,
especially in hybrid risk patient, right?
Yeah, in hybrid risk patients.
But I'm considering this case.
Patients.
I'm considering this case. This is a young patient, long stand, multiple steps, multiple procedures, long procedural times. So I'm thinking about the what study DAPT. Thank you very much.
Just the final angio. The final angio.
Without wire.
This is for you.
Okay. Thank you very much.
Thank you, Dr. Gabriele, and thank Dr. Bernhard. And
thank you. It was Gabriele's case. Thank you so much for having
I
us.
must give on behalf of BSA a special thanks to Gabriele and Reimers and his team, and especially I am really
No,
very
Roberta,
grateful to
number one,
Damiano.
and here is team Antonio, everybody.